Welcome, everyone. Thank you so much for joining us today. I know this year's virtual Global Health Week has been really packed full with a lot of great sessions. I think I heard there were more this year than we've ever had before. So it's been really exciting. We're super happy that you guys were able to join us today. Obviously, been a challenging year for global health, but I think that makes all the work that you've been doing, even more important. And these sessions are kind of a nice way to reflect on, where we're at as the year is sort of winding down and think about what we're going to focus on for next year. So for this session today, we're going to be talking about AI and the role it plays in global health now and into the future. And we know AI is complex and rapidly changing, but we know it's going to have an impact on public health and global health. And so really, I think we all just kind of have to be prepared for that. And really importantly, it's critical that global health experts of all kinds are in discussions about how we're going to use AI in our field. There's tons of opportunities with AI in global health, things like potentially improving clinical care and diagnostics, increasing systems efficiencies, increasing patient engagement, improving access to care. But there's also a lot of potential risks, right? So things like medical errors, privacy and data sharing, and potentially kind of perpetuating existing health disparities. And so that's why it's really important for the global health community to be engaged in decision making around AI, so that we can really guide its use and ensure that it's helping us reach our goals that we've set for global health. And so today's session, I'm sure will not answer all of your questions, but we hope that it can serve as a jumping off point for future discussions and further activities, both within CUGH, but also, in your institutions and wherever you are working or based. And so before I dive into my talk, I just wanted to give a little background about the origin of this session and how we ended up here in this virtual Global Health Week. So there's been a lot of activity around AI at CUGH this year, and that I thought I would share. I will caveat that this is from sort of my perspective and involvement in these activities, so I'm sure there's a lot more that is not included throughout, the various work groups and committees and other folks involved with CUGH. But in 2024, the CUGH Research Committee launched an AI work group. So that was within the research committee. This was led by Dr. Wenwei Mao of Duke University, and I was a co-chair of that group. And we really focused on two main tasks that year. We conducted a landscape review of AI and global health, looking across various domains, including education and training, public health, disease surveillance, clinical applications, and health system strengthening and optimization. And then we leveraged these findings to put together a pre-satellite conference session for the CUGH conference in Atlanta earlier this year, which was titled Harnessing Technology and AI for Collaborative Breakthroughs in Global Health. And our session had some reviews of AI implementation, policies, and perspectives. We included trainees' perspectives. We had TAC representatives from CUGH, which was fantastic, and covered some case studies using AI, such as AI-supported diagnostics for TB in Uganda, AI chatbots for supporting clinical care in Nigeria, and then the use of AI for cancer screening tools, as well as risk-stratified care in low-resource settings. And so the session, I think, was a really big success. We had a lot of people come. We had people come with big, great questions and had a lot of fantastic discussion about AI and global health. And so from that, it was really clear that there's just more work that we need to be doing. And so today we are continuing that conversation, diving in a bit more into some of the nitty-gritty of what AI is and how we can use it. And really just trying to think about our role as global health practitioners and what that should look like as AI is rapidly changing our field. And so we're really glad that you're all here today to be a part of this conversation. And so our session today, just for a quick overview of what this is going to look like, we have it broken into two parts. So once I finish with this quick overview and introduction, I'm going to talk about some background on AI and its use in global health, really leaning heavily on my experience as an infectious disease epidemiologist. And then I'll turn it over to my colleague, Dr. Shama Patel, who is also part of the CUGH Research Committee AI Working Group. And she will share her perspective from as a clinician and a clinical educator. And then from there, we will go into our part two, which is a moderated discussion, which will be led by Dr. Jawad Noon, who is the co-chair of the CUGH AI Working Group. And he will guide us through some discussion with some four really outstanding panelists that we're really lucky to have today, with a wide range of knowledge and expertise. And this is definitely not, the end. This is really kind of the beginning of some of these conversations. So Jawad and I together are co-chairing a brand new AI working group here at CUGH. It's being moved out of the CUGH Research Committee and into a consortium-wide work group. And that will allow us to expand our scope and participation. Participants in CUGH work groups do not have to be members of CUGH committees, and they actually don't have to be members of CUGH itself. So we can really engage across, a variety of different disciplines, geographies, and organizations. So we're really excited about that. This is very new. I think maybe technically we aren't a work group yet because I'm not sure we've done all the paperwork, but it is coming and we're really excited. So we just wanted to share this with everybody. And the mission of this work group is going to be to improve the well-being of people on the planet by advancing innovative, ethical, and equitable integration of AI into global health through education, research, service, and advocacy. And so we hope that the work group can become a key source of information for CUGH and anyone in global health, including things like providing quick resources, curriculum and training guidance, evidence-based advocacy, and both virtual and in-person sessions. So you'll definitely hear more about this in the future, but if you have any questions, you can always feel free to reach out to myself or Jawad. And so with that, I'm going to transition into the first kind of content talk for our session. And I am going to be talking about my perspectives on AI as an epidemiologist. So for some quick background, I have my PhD in infectious disease epidemiology, and most of my PhD and postdoc work was applying spatial and social epidemiology to inform targeted case finding for TB in Uganda. I spent a lot of time on the ground with our data collection teams, working with both routine health data systems as well as, study-specific data collection systems. And since then, I have joined Georgetown University, the Center for Global Health Practice and Impact on their faculty. And I support kind of a range of projects, but this includes some PEPFAR implementation in multiple countries, as well as providing technical assistance under the Ending the HIV Epidemic program for U.S. health departments. I kind of consider myself an applied epidemiologist. So while I'm currently working in academia, I've worked for NGOs, state health departments, and the CDC. So trying to bring that very practical, programmatic approach to epi and global health. And now AI, I've kind of stumbled into doing a bunch of AI work. I do want to preface this presentation by saying I am absolutely not an expert on AI. I have just been trying to learn enough to sort of keep up with what's going on in my field. But I've spent a lot of time, trying to figure this out. And so hopefully I'm able to pass on some of that knowledge to you guys today. So I see we have a very active chat, and so I'd love to keep that going. So I'd love to hear from folks what AI means to you. And I think this could be as broad as you like. What AI have you used? Are you familiar with? Are you excited about it? Do you have concerns? So go ahead, we can use that chat and I'll keep an eye on it, but to kind of keep this discussion going and kind of get a sense of what folks are thinking of when we talk about AI. Yeah, so things like chat GPT, algorithms, scary, automation, optimizing, large language models, awesome. Yeah, so all sorts of great ideas here. And this is fantastic and really kind of sets us up for what we're going to be talking about. So it sounds like people are generally familiar with some parts of AI. At this point, whether you want to or not, you probably are using AI in your life. Most of our phones have digital assistants, things like Siri or Alexa. Your Facebook or Instagram feeds, for those who are younger than me, maybe TikTok, they're all controlled and curated by AI to show you what they think you want to see. AI is used for facial recognition, fraud detection, or even seeing self-driving cars now that are controlled by AI. So it really is kind of everywhere. And so, in terms of defining what AI or artificial intelligence means, we define it broadly as just systems that perform tasks that normally require human intelligence. And it can be a little tricky to define human intelligence, but generally, what we're thinking about with this is things like learning from experience, understanding context and nuance, problem solving, and applying values, ethics, and social norms. So if we think back, 10, 15 years, at the time, the idea of something like a self-driving car or the facial recognition technology we're using, the idea that that could just be done by computers was a little hard to believe. And now we really are seeing it with generally good results. We can get into some of the challenges as well. So if AI is a system, that's mimicking or kind of copying this human intelligence, and we know human intelligence is really complex, that just means that there's a lot of ways to do that. And so that's true. AI really encompasses a lot of different technologies, and I think that's why it can be a little confusing. But you can think of AI as like a toolbox or a recipe, or maybe a cookbook might be a slightly better way to frame it. But it's something that you can use to help you get an end result that you're looking for. And obviously, AI is kind of having a big moment right now, but it's important to know that this isn't a brand new idea. So the concept and development of AI goes back to the 1950s. And if you look over time, we see periods where AI development rapidly grows. And then there are what we call AI winters. And this is where the AI research sort of hits a dead end. A lot of times this happens when there's kind of a lot of hype about AI. And then you get this period of sort of disillusionment that follows, often due to kind of over-promising of results that the technology really couldn't deliver at the time. So right now we are definitely in that AI boom, but it's not really clear what that trajectory is going to look like from here. So getting into the weeds a little bit more about what AI is. So we said it's a toolbox, and we're going to look a little bit more specifically at what those tools are. And some of the things we're going to talk about you may have heard of or seen or maybe have even used, but they are machine learning, deep learning, and generative AI. So machine learning is a subset of AI that focuses on developing algorithms and statistical models that enable computers to learn from and make predictions or decisions based on their data. Deep learning is then a subset of that focuses on using artificial neural networks to learn from large amounts of data. And so these neural networks are composed of multiple layers. That's where the term deep comes from, because it's all the layers working together that enable the model to extract features from your data or from your information. Deep learning has been particularly successful for things like image recognition, natural language processing, and speech recognition. And then kind of within that, a further subset is generative AI. And so generative AI refers to the branch of AI that focuses on creating new content. So this could be images, text, music, or videos. And the idea is that it looks like something a human created. Generative AI uses deep learning models a lot of the time. So you may have heard of general adversarial networks or variational autoencoders, or if you haven't, that's fine too. But these are tools that are used to help create those sort of realistic and novel outputs. And so large language models can fall into that, things like ChatGPT or Claude. If you've used any of those, I think I saw some folks mention ChatGPT in the chat already. So, we've kind of laid the groundwork for what AI is and what some of these types are. So again, I'm going to ask those of you who are engaging with the chat to continue to do so. And we'd love to hear what you think AI can be used for in global health. So these might be things you have done or you have seen, or just ideas that you'd love or you think we could use AI in the context of global health. So feel free to type in the chat and we'll kind of see, keep an eye on what people are thinking. Great. I'm seeing stuff, diagnosis, tests, things like diagnostics. Great. Awesome. Yeah, please keep sharing. We'd love to hear other ideas, outbreaks, tracking medication resistance. Amazing. Great. Well, thank you so much for sharing these. I love it. So another way to kind of just break out or break down what AI is or the different types of AI is kind of think about the purpose that we're using it for. And so then we can consider AI either that generative piece or predictive. And so again, we talked about that generative piece. That's where you're creating something new. So maybe you've used, ChatGPT or any of those types of programs to create figures for a presentation, to help you draft an outline or brainstorm for a paper, or maybe just creating funny images. That's fun too. On the other side, we have what we call predictive AI, which is focused on using data to make predictions. And that can let us provide recommendations, do forecasting, or kind of make diagnoses. And so basically at a high level, what that is we put some data into the system, we let it do its thing, and then we get our result. And so within global health, there's a lot of ways that we can think about predictive AI being useful, and I've already seen a whole bunch in the chat. So we're really, for my talk today, we're going to focus mostly on predictive AI from here out, which is not to say that generative AI doesn't have a role and isn't important, but I think there's a lot of predictive AI ideas and opportunities that are worth talking about. And so some of those ideas are here kind of broken into sort of general themes or buckets of ways that we can use predictive AI. Definitely not exclusive, but some things that we are seeing in global health include using AI for individual risk stratification. So for example, using patient data to identify patients who might be likely to interrupt their HIV treatment. And then we can intervene earlier and provide supportive services to try to prevent that. AI can also be used for outbreak prediction and early warning systems. I think I saw some folks mentioning that in the chat. And rapid diagnostics. I think this was also common response in the chat. So one example we have here is the computer-aided detection for TB. And so that uses AI to interpret chest x-rays and estimate the likelihood that a patient has TB without needing a trained radiologist to look at those x-rays. And then a fourth potential use is kind of spatial hotspot identification. And again, informing that targeted outreach, whether that's screening or education or other types of outreach we can do in our communities. But I do want to emphasize, these are all great opportunities. These are all things we've been doing in global health and in public health. So AI is really just a tool we can use to potentially make these activities faster, cheaper, or more accessible. And in that way, really, I think of it as sort of an extension of our own work that we're already doing, or even just a tool to kind of help improve the work that we're already doing. And so these kind of applications of specifically predictive AI in global health was something I was really interested in understanding. I think I would hear a lot of people talk about it, but really wanted to know kind of what is being done out there. What are folks implementing? And so my team conducted a scoping review of applications of predictive AI in global health. For feasibility purposes, at least for now, we focused on Africa specifically, but the intention is that this could be something that we do at a global level. And so for this review, we included any studies that had individual patient or population data and any form of predictive AI. And I do want to say this work was led by one of my undergraduate students, Sara Bidiwala, and we had a lot of support from our team here at Georgetown as well. So big shout out to them for all of this work. And so in this review, we found 80 relevant studies covering 35 countries. Some of them are highlighted on the map here, and then some studies were kind of multi-country as well. And overall, most of the studies were using kind of general machine learning models. We did see a few that were using sort of those more advanced or detailed models like neural network deep learning models, but mostly kind of traditional machine learning. And then in terms of what the context or health issue that they were looking at, a lot of it was COVID, which I think makes sense kind of given the timeline of the COVID epidemic, as well as the timeline of AI's kind of expansion. But then we also saw quite a few papers on HIV, birth and gestational outcomes in TB, and then a whole range of other topics as well. So I think for me, the takeaway from this is that, it's really confirming that predictive AI is being developed and deployed in global health settings. And in particular, it's a lot of machine learning. So I thought I would kind of dive into that a little bit more. So machine learning, as we said, this is sort of a subset of AI that uses algorithms and models for prediction. There's different types of machine learning. So every time you learn something, you can kind of get a little more in the weeds and find out there's always more types of things. So with machine learning, we can have supervised machine learning or unsupervised machine learning. And then there's a third type that's called reinforcement learning. Supervised machine learning means that you are giving the system what we call labeled data. So this means that your input and your output are clearly provided to the system. In epidemiology terms, which is how I think about things, you can think of this as like your exposures and your outcomes. And basically you're saying to the model, here's the outcome I'm interested in. Here's the information I have to input into this model. How do I connect the two? What's the link? What's the algorithm that gets me from my exposures to my outcome? And with supervised learning, we can do either classification or regression. So classification is where our model is just dividing our data into categories. So you could think a simple example could just be like positive or negative, or different groups, different risk groups. Regression, on the other hand, is giving us like a specific value that we generally treat as like a risk score, like how likely it is that something is going to happen. So that is our supervised learning. Unsupervised learning, you're basically giving the system a bunch of data and asking it to find patterns for you. So it's useful for things like clustering of information. And it can be used to kind of find these patterns or these clusters and make recommendations. So one example might be that a company that like an Amazon or someone who's selling stuff can use this to identify products that are often purchased together so that they can make recommendations to the user that those things kind of go together and they might be interested in that. And then our third type is reinforcement learning. This is where the model is learning from the environment. So it's a little different. It's not that kind of static data set. And this is how we could train an agent to take action. So you might think of this as how we would train like a robot to figure out how to navigate a maze. So 3 types of machine learning: supervised, unsupervised, and reinforcement. In global health, at least in terms of what I have seen and what we found in our review, is that we're primarily seeing supervised machine learning, either for classification or regression purposes. You may have heard of some of these methods, things like decision trees, random forests, our XGBoost. But even if not, it's just kind of helpful to understand the landscape of the types of things people are implementing. So let's talk a little bit about what does it look like when we actually implement some of these models. And again, focusing on this predictive AI and specifically machine learning contexts. Really, what we're doing is the process is pretty similar to what we would have done for any predictive modeling in the past when we were just using kind of statistics and other mathematical properties. We're going to take some historical or existing data, build an algorithm that predicts an outcome we're interested in. In the context of health, this could be a disease diagnosis, could be, risk of mortality. And we're going to do that by training the model on our data. And then we're going to test that model on some new data. So this is kind of the process for building predictive models. In the context of global health, a lot of times our data is coming from our programs. So it's often these sort of closed or isolated data sets. We're not pulling information from the internet or all over the world. We're looking at, our electronic health records or our program documentation. The inputs into the model might be things like risk factors, demographics, symptoms, lab results, sometimes some geographic or spatial information about where people live or where they're getting their treatments. And we use that information to train the model to estimate the likelihood of an outcome we're interested in. And again, this could be a score or a probability that's like a risk score, or it could just be kind of a classification. So again, like a positive negative is a simple classification. Just like any statistical models we did before AI, our results are going to be completely dependent on the data we give it. And it's going to be subject to the challenges that we face when we do our traditional epi analysis. So things like confounding, bias, measurement error, missing data. All of these are still going to be concerns when we're working with predictive AI. We also need to remember that with these models, it's not necessarily telling us about a causal relationship. It's just kind of connecting and finding an association for us, but it's not necessarily telling us that our exposure is causing our outcome, just like a statistical model doesn't necessarily tell you that. So when you're looking at predictive models, it's really important to know what data the model's been trained on, and to understand the validation process. So we really can't assume that a model that works on one data set is just going to automatically work on another. Or to think about it a little differently, a model developed for one population, so we're generally thinking about populations in global health, is not necessarily going to work in a different population. And so that's where we really want to understand a little bit more about the validation process so we can make informed decisions about the use of models. So validation is the process that we use to test the model, basically making sure it works. Internal validation is using the same data set or population, so often by setting aside a portion of the data when we're developing our model that we can use to validate on after. That internal validation tells you how good your model is in that population, but it doesn't tell you if that model will work in other populations or other settings. And so that internal validation alone, which is often what you are reading about in peer-reviewed papers applying predictive modeling, it tells you that it works in that setting, which may be enough information for you, but it does not tell you that it'll work in a different setting. And so that's where we need the external validation process. External validation involves testing the model on a different data set or a different population. So for example, maybe you have a model that was built to predict risk of dropping out of HIV care in South Africa, and you're in Nigeria and you want to use that model. Just because it worked in South Africa doesn't mean you can just plug it in and it's going to work in your setting. So that's where you want to think about that external validation piece. So external validation is super important, and it helps kind of address a lot of concerns about what you're going to get from your predictive AI models. It helps understand real world performance. So does the model actually work in a real world setting? It can help address equity and fairness. So it'll reveal whether the model performs differently in, different age groups, across, racial groups, across geographies. If we're using predictions to inform things like triage or risk scoring, it's going to have an impact on patient safety. It's also going to tell us about the context fit. So maybe the model was developed somewhere that uses a different data system or a different workflow. And so that doesn't necessarily translate to a new setting. And then finally, this trust and adoption piece is really important. Programs and clinicians and communities are more likely to use AI tools that have transparent validation. And people are often easily scared off by one poor implementation of AI. So we really want to do our due diligence before we implement things. So again, I know this is a little technical. Most of us are not going to be the ones doing that model development and validation. But if you're thinking about potentially using a predictive model in your setting, these are things to be kind of take under consideration. So you want to make sure you're looking for or doing that external validation, doing some equity checks, comparing to standard practice to make sure it's as good or better than what you are already doing, or in other words, that there's some benefit of the AI. Pilot testing will give you a ton of this information, especially that kind of context-specific piece. And then ongoing monitoring. So populations change, right? So a model maybe worked great in your population 5 years ago, but as things change, maybe it's not as good anymore. And so we want to make sure we are doing that long-term monitoring as well, and not just implementing and letting things go. So I would say what I've seen anecdotally as the challenge is that, and this is not specific to health alone, we're kind of trying to implement AI quickly to try to keep up with kind of loss of resources and things like that. But people aren't always taking the time to do all of this external validation. And that can lead to serious issues when it comes to implementing AI. Right. And so even with validation, AI is a model, it's a tool, and it's not going to be perfect. And so when we're developing these tools and thinking about implementing them, we need to ask ourselves, how much error are we willing to tolerate? And what is the consequence of those errors? And so I have a reference to a book up here, AI Snake Oil. This was actually recommended to me by one of my students. And I thought it just did a really nice job of laying out some of the limitations of predictive AI in real world settings. So it's not specific to health or global health. They talked about a lot of different scenarios, things like policing, hiring algorithms, facial expression analysis, and college student success prediction. And these are all real scenarios where AI was used. And there were major challenges or even failures as a result of that. And some of these errors, they might seem innocuous. So if you think about the college student success prediction, the model's just going to say if it thinks this student is going to succeed or not. And in the examples they had, it's based on things like family income and zip code. So you could incorrectly classify a student as unlikely to succeed. That in itself is not necessarily a problem. The problem comes in if a university is using that to decide whether to admit that student, because then they might not. And then that student doesn't necessarily get the education that they would have succeeded in, all because, a model was followed kind of blindly, right? And so it's really that kind of lack of human oversight on the models where we see, potentially huge impact on people's lives. So kind of bringing that back to our health perspective, in health, it is life and death sometimes, and there are a lot of consequences. And so these are things, again, not to be like to scare people or to be like too much of a skeptic, but things to think about when you want to use predictive AI in your settings. So some things that can happen include potentially misprioritizing your testing or treatment procedures, either missing high-risk patients or falsely identifying low-risk patients as high risk, and so you're devoting resources to them that you might not have needed to. You're putting more burden on the patient if you're doing that as well. I think this is one we're all really aware of, worsening inequities across regions or populations. So if a model only works well for certain populations or certain groups, you risk kind of widening the gaps that we already see between populations such as rural or urban, based on income, based on gender, age, race, all of these things. AI also has the potential to disrupt your workflow if we're using it in clinical settings, potentially, causing people to need to double check results that they didn't need to. Can slow down your clinical flow. It can shift burdens in ways that aren't optimal for healthcare systems. If we have models that make mistakes when we're trying to predict outbreaks and create outbreak alerts, obviously a false alarm is a massive use of resources that we didn't need to use. But also systems like this can kind of create a false sense of security. And then we kind of take away, again, that human piece of that manual oversight and vigilance that we currently use when we're trying to monitor for outbreaks. Other potential errors including, inappropriate triage decisions in clinical settings. If we're using predictive AI for supply chain forecasting, can lead to stockouts, or on the other hand, overstocking of certain things, which may go bad or you may not have room for. It can affect how we do our public health messaging if we kind of over target or underreach certain groups based on our algorithms. Can make some wrong decisions in terms of program planning. And ultimately, all of this can really erode trust in digital tools. This is true across all perspectives. From a clinical perspective, clinicians may not want to use these tools anymore if they feel like they're not working. Patients may not want to engage with them. Communities might not want to be a part of it. And so all of these things, these potential negative consequences of our implementation of predictive AI. So, of course, I'm going to be very biased as an epidemiologist, but this is where I see kind of the epidemiology piece and, just broadly kind of global health kind of providing that human component that helps prevent some of these errors and issues. And so, I'll say, I don't think this is the first time that there's been what could be considered a disruptive technology that's affected my path as an epidemiologist. When I first started grad school was when there was kind of that huge rise in data science. And I felt like everyone wanted to be a data scientist. Every company was hiring data scientists. And it was great to see that like rapid expansion of analytic capacity and capability. But I also remember people telling me that like my career was obsolete. We don't need epidemiology anymore because like the computers, the people who write the code and run the computers can solve all of your problems. Obviously, that did not turn out to be the case. After COVID, especially, epidemiology is a household word. I think most people still think that it's very important in the context of global health. But it did make me wonder, how is AI affecting this? What is the role of AI in my work, and where is that kind of epi component still really relevant? And so I think from that epi side and broadly the global health community, what we provide is sort of that theory, guardrails, and structure to our implementation of models. Epi itself helps us understand causes of disease. It really defines our data structure and moves us towards causal reasoning. And in particular, one challenge that a lot of the AI models have is that while they may be good at their predictions, they don't necessarily tell you why that is happening or what is driving that. There are tools that can help you unpack that more, but that piece of understanding why you're getting those high, why you're categorizing someone as high risk is really important. And I think that's something that, bringing in the expertise from the global health side will be really critical. On the other side, predictive AI provides speed, scalability, and flexibility. It helps us predict our future risks. It can be better at working with complex data and can help us anticipate things and therefore make better decisions. So both pieces are really providing critical information. And I think they really operate well together if we think about them as kind of something that we implement sort of side by side, drawing from the best of both. And again, the most important piece is going to be that human input. And one of the main risks that's kind of been identified with predictive AI is, again, when there's not that human oversight and we put too much trust in a single algorithm to make decisions for us. And so bringing in our expertise and our knowledge and our ability to understand context and situations still becomes or remains critically important when we're using AI. So to wrap up, from my perspective, I think AI is it's a set of tools. It's really powerful, but it's also imperfect. And it works best when we're bringing together data, that human input, and context. And so I've talked about this from kind of an epidemiology perspective, because that's how I think about things. But I think we can all do that. You all working in global health have all of this knowledge and information that should be informing how we use predictive AI. Focusing on responsible design, including performance, but also equity. I think in global health in particular, we're really aware of potential equity issues with AI. But I do think, I may have sounded a little negative and a little skeptical. I do think that AI can really strengthen global health systems. It just needs to be used really thoughtfully, and we need to understand what it's doing. And I just want to say, I think everyone can and should learn the basics. And I know that's why some of you are here today, and that's fantastic. But you don't need to be a data scientist. You don't need to be an epidemiologist. We can all learn enough that we can engage with AI better in our fields. So I hope that you learned a little bit from this presentation, and encourage you to keep learning and keep engaging with AI. I think it's really important for global health clinicians, practitioners of all sorts, to be at the table and really participate in these conversations. There's going to be big decisions to be made about the use of predictive AI in global health, and everyone here should be part of those discussions. All right, and so with that, thank you so much. I am going to turn it over to Dr. Shama Patel for her presentation. I'm happy to respond to questions in the chat or through the Q&A box. And before I go, I just want to acknowledge all the folks at CUGH who are making this work possible, including the research committee, the AI Workgroup, the leadership, the staff that helped with the webinars and everything, as well as the folks here at Georgetown who helped with that review, and who I have learned so much about AI from them as well. So with that, I will turn it over to Shama.
Hi, everybody. So just give me a second. Okay, so my name is Shama Patel. I'm actually started in global health about 20 years ago. Actually, this year was be 20 years with PEPFAR. And then about a little more than a decade ago, went into medicine and I became an emergency physician. And I've been doing that. And now for the past about year and a half, have transitioned into AI. The first 6 months, about a year, I was just kind of learning. And really why I decided to delve into AI and learn more about it was during COVID, I was in a lot of different hotspots, both domestically and internationally. And I got a little bit sick of things being told to me and decided for me. And looking at AI and the amount of funding and resources that are being put into it, I decided that instead of letting it happen to me and to colleagues and to my field, I wanted to learn more about it. So I'm going to talk more about generative AI. So some of this will be repeating a little bit of what Catherine said, but hopefully it'll be some new information as well. So again, my name is Shama Patel. I'm an emergency physician and working in global health. And my AI focus is kind of twofold: one on AI literacy and governance, as well as I've actually spent the last about 6 months training large language models on medical and public health refinement, and refining those models to be more accurate and to be less definitive on the recommendations. So it's been an interesting transition because I've spent most of, if not all my career, either in government, nonprofit, or academia. So working for private tech companies has been a large transition. But I think more of us, as you'll see through my talk, it's a bit of a soapbox that more of us have to be at these tables, leading the conversation across the globe if we really want to maintain a leadership role in this field, as well as make sure that we're not exploiting more people with the fast pace with which AI is kind of inundating all of our lives. So I do want to be upfront as well. I am not an expert in AI or a computer scientist or a data scientist, but I do believe deeply in the potential of technology. So if we in healthcare and in global health become literate, get seats at the decision-making tables, and ensure the equitable, context-specific, and locally responsive deployment of AI tools, I think this can be a game changer in providing equitable care throughout the billions of people that are still not receiving any. And especially with our funding situation the way that it is, I think this is the opportune time for us to think novelly and innovatively about where we go from here. So understanding AI in the healthcare context. So we talked about this, Catherine did. So artificial intelligence, as you guys have said, there's a lot of words that are associated with it: algorithm, automation, prediction. So artificial intelligence is a broad field of technologies that are designed to mimic human intelligence. So everything from chess playing programs to medical diagnostic systems. Then machine learning is kind of a subset of artificial intelligence, which is discussed in our previous presentation. But instead, so what it is, it's not explicitly programmed, but instead it learns from patterns of data. So again, for example, it'll show an algorithm thousands of chest x-rays, and it'll label it either as pneumonia or normal, and that algorithm will learn the patterns, and then when it's given a new image from that learned behavior, what we call unsupervised learning, will decide if it's pneumonia or normal based on that previous supervised learning. So deep learning takes it a bit further. This uses neural networks, which is inspired by the human brain structure. So these models use layered neural networking that mimic the way neurons are connected in the brain. So the goal is to handle extremely complex pattern recognition. So like detecting diabetic retinopathy on retinal scans, for example, or melanoma on skin in terms of dermatology. So this architecture is why AI is so good at image interpretation, and it enables AI to read medical images at a massive scale. So a lot of the AI in medicine has focused on this diagnostic work. So image recognition, x-rays, CAT scans, skin findings, tumor markers, pathology, because it's an, I wouldn't say easy, but a more finite way of teaching these neural networks how to interpret images and language. So the next step is generative AI, and that's more of what I'm going to talk about today. So it represents a paradigm shift. Rather than just analyzing existing data, generative AI creates new content. So for example, right now, in a lot of my clinical role, we use a lot of ambient AI. So the it's not recorded, but on my phone, or if I'm on a telemedicine call, it will listen to my conversation with the patient, not have any identifiers, but from that conversation, it will develop a clinical note for me, which for anybody in the audience knows, when you're a clinician, writing notes is the bane of your existence. It is the thing that takes up too much of your time that you can't actually do the patient care that you were trained for and want to do. So in my opinion, it has really changed the game for me in terms of my work satisfaction and my efficiency and ability to take care of my patients. And so you can also use it to generate patient education materials, because right now there's been so much data on discharge instructions given from the ER. Obviously, I'm an ER physician, so a lot of my experience has been from that. I mean, it's just thrown away because either the literacy level is not there, the language is not there, it's not explained in a way that's understood by a patient. So this generative AI, it's a simple way, but it can actually create this from existing materials, but modify it and tailor it to the actual patient. And what's exciting too is that it can, generative AI can be used for personalized treatment protocols. And in education, it can help reduce the burden of curriculum development, exam questions, and personalized learning. So the creative capability is what makes generative AI so transformative. The progression from basic AI to generative capabilities represents the evolution that's now transforming healthcare worldwide. So understanding these distinctions matters because each type of AI solves different problems in health and in medical education. So we talked about predictive AI earlier. That's just one component of this. And generative AI is another component. And you'll hear other words being thrown around now about agentic AI, edge AI. I'm going to touch on a little bit of that at the end, but really I want to focus on generative AI, which is where all of the traction is happening right now in healthcare. So the healthcare AI market, the numbers tell a compelling story about where healthcare is heading. So the global AI healthcare market is exploding from 11 billion in 2021 to a projected 188 billion by 2030. That's a 17-fold increase in less than a decade. It's not an incremental improvement, but an exponential transformation. And so, with the speed that this is going, we have to be at the table. Anybody in health, anybody with a focus on equity and healthcare and medicine and education, all of us need to be at this table to make sure that we're doing this correctly and that it's not just about the new shiny little toy. So, why such an explosive growth? Because AI addresses a critical health challenge. It really does. That has resisted traditional solutions for decades. So, as many of us know, we've done, and many of us that have been in global health and in health for a while realize that we tend to do things the same sometimes and not really change how we're doing it. I think AI is a paradigm shift for all of us to change how we do all of our healthcare, I think. And especially with the limited access to resources and funding, I think it's an opportunity right now for us to change how we approach this in a fundamental and monumental way. So the two key growth areas that are driving the investment in health is medicine, clinical diagnostics, decision making, treatment optimization, and drug discovery, as well as in public health and global health, where AI's ability to extend specialist expertise to resource limited settings is proving truly transformative. And for those of you who were at our session in the spring, we talked a lot about this, and a lot of organizations throughout the world are developing from the ground for their local population these chatbots and AI agents that are helping democratize care and reaching more populations and providing decentralized care and more access to specialized care, which is great. So the growth reflects a genuine need. And because healthcare and global health has historically been late to adopt technologies, this one is one of the first times we can get ahead of the curve and shape how these tools are built, validated, and deployed. So why AI matters for global health? Think of it as a force multiplier. So it's addressing our most persistent fundamental challenges. So I kind of put them into 4 buckets. So reach, AI extends our specialist care to where it doesn't exist. A good 2 billion people still live in rural, disconnected areas. So a community health worker in rural Kenya with nothing but a smartphone, and we all know that the majority, you may not have running water, but likelihood you will have a smartphone, can now access diagnostic AI that brings radiology expertise to places where there was no radiologist. This isn't future speculation. It is happening now, and it's happening from the ground up, being built by local communities for local communities. So the speed is another bucket. In time-critical emergencies, AI analyzes data instantly. So sepsis prediction algorithms can alert clinicians 6 to 12 hours before clinical deterioration becomes obvious, which is a game changer when you have busy ERs and busy hospitals and limited nursing and specialty care. It gives you in critical infections, minutes matter, and AI delivers those minutes by predicting these things earlier. Accuracy, so AI improves diagnostic precision where specialists are scarce or absent. So diabetic retinopathy screening at a specialist level accuracy has been deployed in a massive scale, for example, in India. TB detection on chest ray has been validated by the WHO. This all brings specialist quality diagnostics to primary care settings. So just so you know, the first about half the presentation will be a little bit about yay AI, and then don't worry, for the skeptics out there, which I'm definitely one of them, we'll talk about the pitfalls. And the fourth kind of bucket is efficiency. So AI optimizes scarce resources. It predicts, like predicting blood products where the need would be, where medication should be stockpiled, in triaging patients so the sickest get seen first, allocating our limited resources and medical supplies where they're needed most, and real-time demand forecasting. So critically for global health, AI can do more with less, which unfortunately, the state of the world will have to be doing with more with less as we move forward. So it amplifies the impact of limited healthcare workforces and infrastructure. So a $5,000 AI diagnostic algorithm can provide what would otherwise require a 50,000 per year specialist. That math changes what's possible. So now to get to more of the nitty gritty. So let's get specific about clinical applications, which is what I'm going to more focus on. So this slide gives a high level overview of where diagnostic AI is actively deployed currently. So computer vision, which some of you may have heard of, may not have heard of, it analyzes medical images. So tools like CUGH AI automatically detect pneumonia on chest X-ray with accuracy matching experienced radiologists. So WHO again has validated several TB detection AI tools that sensitivity is exceeding 90%. Portable ultrasound devices, which I actually use a lot of with AI interpretation, are bringing obstetric, but also lung ultrasound and other specific system ultrasounds to rural clinics where there aren't sonographers with real time or a very limited delay in image interpretation from experts. So it's really a big game changer. So I'm going to skip over a little bit of predictive AI because we talked a lot about it in the previous presentation. But really, it can assess risk before it becomes clinically obvious, which when we have limited resources, it's really important. And point of care tools can bring diagnostics directly to the patient wherever they are. So this is democratizing diagnostics. We're really seeing an impact of this globally. So smartphone apps for detection of TB, for chest x-rays can be uploaded directly to the smartphone and you can get analysis in seconds. AI enhanced dermatology apps for skin conditions, rapid malaria detection for smartphone photos of blood smears, and then rapid triage algorithms help prioritize the sickest patients when waiting rooms in communities are full and don't have resources. And again, AI-enabled portable ultrasound is bringing game-changing diagnostics to the bedside in very rural digital deserts. So the key philosophical insight is that these tools don't replace clinicians. They extend specialist expertise to places it could not reach before. So instead of training a specialist, which takes years and costs thousands, you can do the same specialist level care, hopefully soon, without having to invest that much and being able to do at a fraction of the cost. So generative AI in clinical practice. This represents another shift that AI can do for healthcare. So up until recently, AI could analyze, categorize, and predict, but now it can create. So first, clinical documentation. I had talked about how I use ambient AI scribes on a daily basis during my clinical work. So it's the most widely deployed generative AI in healthcare with over 60 vendors competing in what's now $1 billion market. And so ambient scribes like Dragon, Napla, those that are clinicians probably have heard of these, listen passively to patient encounters without recording for privacy and automatically generate structured clinical notes in real time. So the impact is that physicians save 60 to 70% of documentation time, which is huge. It's about 1 hour per day, which may seem little, but that is translated to direct patient care and actually being able to do a medicine how we want to do medicine. So, and a concrete example is Kaiser Permanente, which is a large health system, mainly operated in California, in the United States, has documented savings of nearly 16,000 physician hours in just 1 year of using ambient scribes. With over 3,000 physicians at Kaiser, this is not just a projected savings, it's a measured, documented return to patients, and it saves money for the health system as a whole. So for global health, the current challenge is most platforms require internet connectivity. And I'll be talking about very briefly Edge AI, which is really exciting and I'm very interested in, run entirely on smartphones without cloud dependency and are in active pilots right now. So they're a fully enclosed system that don't require any access to any broadband or a digital network. So within 2 to 3 years, a clinician in a rural health post with intermittent electricity and no internet will be able to use ambient scribes and that will also change how they do things, and they can document more correctly. And we can use that in our epidemiological work and our global health work to be more accurate on disease prevalence and predictive analysis. So second is clinical decision support. So AI generates personalized treatment protocols, accounting for local drug formularies and resource constraints. So this is essentially where the WHO essential medicine lists differ dramatically from high country standards. So tools can be used that directly reflect your local resources versus trying to do a global scale on this is how clinical decisions should be done, but it can be localized and context specific. So right now there's a lot of these are unfortunately still US based, but hopefully this will get people excited to invest and implement some larger scale and more reflective for the global context. So open evidence, Glass Health, UpToDate, they've all integrated and built on AI systems. So third, patient communication, which is huge. Generative AI can help with multilingual education materials, culturally appropriate adapted instructions. It can also help with languages that aren't, the WHO's 6 main languages. There's thousands of languages spoken all over the world, and this can help bridge that gap. And so people actually get more ownership and autonomy over their healthcare. So traditional challenges in global health education. I think a lot of us know these already. There's limited exposure to rare conditions. There's severe faculty shortages, geographic disparities in learning opportunities, and then high stakes anxiety with limited practice opportunities. So students are often trained under high pressure with limited simulation. And so this can be very nerve-wracking for people, and also cause a lot of medical error. And so using generative AI can actually get people more comfortable providing clinical care before actually touching a patient. So the generative AI revolution in medicine. So ChatGPT, for those who don't know, USMLE is there's step 1, step 2, step 3 that we take in the US as medical exams throughout the course of our medical education. So ChatGPT is actually passing USMLE at about a 95% rate. And it's not really that it passes USMLE, that's kind of neither here nor there, but it's that AI's ability to reason through clinical problems step by step is something that's new, and it makes generative AI unique. So 86% of undergraduates have already used AI. Medical schools are adapting instead of resisting. So places like Harvard, GW, Stanford, Mount Sinai have all incorporated AI into their medical education. So this means that learners and increasingly educators are expected to have AI as part of their curriculum. So lastly, just in terms of clinical education, there are some practical use cases. So for personalized AI tutors can identify where a student consistently struggles. This can provide a lot more personalized care. So somebody may struggle with EKG interpretation or acid-base analysis, and it provides a more tailored, personalized learning, but is not so burdensome on limited faculty resources. And AI-generated simulated clinical cases means that students can run through dozens of variations of cases, especially ones that they don't see as often, before they ever meet a real patient. And AI can analyze assessment patterns and help faculty redesign curriculums in real time and make it more iterative. So you're not waiting years for curriculum development or curriculum revisions, that you're doing it in real time and responsive to changing patterns of medicine, as we know happen on a daily basis. So just to kind of go through this one more time, is that generative AI for medical training can be used as conversational AI patients, can be used for content creation for faculty, automated assessment and feedback, as well as breaking language barriers, which I think is huge, and is a great equalizer. Sorry. Okay.
Sorry to interrupt, Shama, but
Yep.
if you're able to wrap up in the next couple minutes so we can include the panel, that'd be great. Thank you so much.
Yeah, this is the fun part. Sorry, guys. So challenges and ethical considerations. I'll go through this fast because we talked about some of it. But this is the stuff I think that we really need to focus on as experts in our field and not experts in technology. So data bias is a critical component. So it's important to know that the AI is only as good as the data it was trained on. So, for example, the dermatology application I mentioned earlier doesn't perform as well on people with darker skin. So these need to be understood prior to implementing any sort of AI tool. The digital infrastructure is another overlooked but really fundamental. Without digital infrastructure, without ability to access the cloud and broadband and mobile networks, it becomes really more of a digital divide than a digital equalizer. And it can also lead to more AI colonialism, which is something else that's really interesting to me. And especially with the big data centers that are opening, they're opening a lot in a lot of the global south, which will increase this division as well. There's a huge regulatory vacuum because no one really knows who is responsible for errors that occur with AI. And so this is a huge part that we in the healthcare world and in global health need to focus on. How do we regulate this? How do we evaluate it? And how do we ensure it's transparent and not exploitative? And then the algorithmic transparency. I don't know if a lot of people that have like studied AI and has even tangential knowledge of AI, there's a big black box problem. And in healthcare and in global health, we get nervous if we don't know where things are coming from. And so to make sure that we're advocating for transparency and that we know exactly what data went into these models and how it was done under what circumstances will help us adopt it more. And there's always the workforce displacement concerns. And I really don't think this is actually as big as people make it out to be, because I think what's going to happen is that the people that do learn AI will replace the people that don't learn AI, but it won't be that AI replaces us. Sorry. And then this is a smart implementation framework that I didn't come up with, but I know colleagues of mine have used, and I think it's great. And when you're evaluating using an AI tool, so you want to start small with low risk applications, especially when we talk about health. So for me, ambient AI for Scribe and for my medical notes was the easiest way to do this because it's a low risk and not directly related to patient care and patient outcomes. Maintain human oversight. So you want to make sure that the human is in the loop. So there's always a human that is reviewing AI and what AI outputs are. Assess accuracy and then validate locally. So as Catherine said, it's not a plug and play. Like you can take one model from one place and put it into another. You want to also respect privacy and prioritize data sovereignty, and then build local capacity while doing this and track developments. So I just want to put a plug in for PATH in Southeast Asia has been doing an exemplary example of this, and this is how they've implemented it. This is from some of their work. So if you ever have a chance, they have webinars that are great in understanding how to implement in real life implementation on AI products. Okay, so quickly, just emerging opportunities. And I'm happy to share all this and discuss after, but federated learning is a great new avenue that's being developed so that smaller countries and smaller data sets can aggregate together and be used to develop context and geographically specific models and not rely on large companies mostly based in the West. Edge AI, which I mentioned before, is a closed system that doesn't rely on mobile networks or cloud storage. Multimedia AI is integrated AI that can integrate multiple sources of data. So nodes, images, labs, ultrasound, genomics to create more personalized care, predictive population health, which we talked about, and then AI discovery. So just a call to action. So this is just things to remember as we advocate and learn about AI is we need infrastructure investment, an open source ecosystem, interdisciplinary collaboration, ethical frameworks, education reform. We can't be doing the same things we've been doing. We need a new way of an innovative way of doing it. And then equity is always our priority. So we have the technology, we just need the will and the wisdom to deploy it. And I think this is us as specialists in our field and not in technology is where our voice needs to be heard the loudest. So takeaway, AI is transforming clinical care and education now, not in the future. Generative AI offers unprecedented opportunities and success requires addressing unique challenges thoughtfully. So make sure that when we move forward that it's any AI integration into your workflow is collaborative, context sensitive, and equity focused. And 3 questions I'm going to leave you with, and then I am done, I promise. Does Does AI, before you ever implement AI, does it save time or reduce burden? Is it safe, transparent, and context appropriate? And is the human still in control of the decision? So I think if these three questions can be answered yes, then you have a good starting point of implementing an AI product or tool into your workflow or your specialty or your daily life. So final thought again, AI won't replace clinicians or educators, but those who learn to safely use AI will replace those who don't. Okay, thank you guys. Sorry we went over. Please reach out for any questions, collaborations, anything at all. And just so you know, AI was used in the generation of this presentation. So thank you guys so much for listening and can't wait to hear the panel.
Thanks, Shama. Over to you, Joanne.
Yeah, thank you so much. We just went through like two wonderful presentations from Catherine and Shama, like Catherine covering the basics, the science behind AI, and Shama covering mostly the clinical part of the clinical application of the AI. In this current panel, we have this amazing panel, a very international panel. We are literally all five of us. We are in literally different countries right now, and for some it's actually night, for some it's day, for some it's early morning. So just to start with, to give you a brief introduction about myself, I'm a medical doctor originally from Pakistan with additional training in policy, economics, and data science and AI. And currently, I'm a research associate at the University of Göttingen in Germany. With regards to this panel, particularly in this session, we'll focus on what actually happens when AI systems meet the real world setting and from a global health perspective. So without further ado, I'll just start with introducing our panelists. We have, and to start with, Dr. Mateo Diaz-Quiroz. He is a medical doctor for Colombia and currently working as health systems data scientist at Causal Foundry and also a department associate at the Harvard Takemi program in international health. Mateo, could you start by telling us what is Causal Foundry and what does your work there and with the Takemi program look like on the ground?
Perfect. Thank you very much, Dr. Noon, for this invitation to this panel and the organizers. And I'm very glad to be with a team of panelists that I truly admire. My name is Mateo. As Dr. Noon said, I'm a medical doctor and I'm currently working as a health systems data scientist at Causal Foundry. Causal Foundry, and to kick off this conversation, and I think that continuing the conversation on the positive note of how AI can be implemented in health systems, I'm working for a company that is implementing AI in real settings in global health. I'm currently based in Rwanda, working on health systems reform on primary healthcare. And we're now shifting towards how to implement artificial intelligence into operationalizing several aspects of health systems and healthcare delivery at a national level. So we are mostly previously during the presentations, you talked about a lot about predictive AI. We have our own AI platform that does predictive AI, but on top of predictive AI, we also do behavioral interventions through machine learning models. So it's the applications of how can these models learn from different interventions and outcomes that it wants to achieve, and how it relearns every time to improve the interventions that it does for specific tasks. We're also working in different countries around Asia and around Africa. I'm also working on another project on Kenya on community health workers to try to provide them AI summaries for their patients and recommendation systems of who should they see at which moment and which is the most efficient way to approach specific patients within their scope of work. So I'm very happy to continue the conversation on how we're doing. And of course, I'm also part of the Takemi program in international health. So I'm both at the intersection between implementation and the Takemi program in international health is more research-based health systems strengthening approach. So I'm working in both sectors on how to integrate AI within global health, but also give it a research perspective.
And with Takemi program, is it specific to Japan, or are you working in different countries on that as well?
Well, it's mostly specific about the project that I'm doing on Rwanda on healthcare reform on primary healthcare. But yeah, as you said, I'm currently based in Rwanda, but in this moment I am in Japan, early morning here. Um, trying to also incorporate AI within health systems here and within hospital care.
Perfect. No, thank you so much. That was wonderful. Um, Next, I would move to Ms. Rajeshwari Subramanian, who is a public health practitioner from India and co-founder of Science to People. So, Rajeshwari, for everyone here, what exactly is Science to People? What do you build? How are you using AI to support public health communication? The floor is up to you.
Thank you so much, Jawad. It's such a pleasure to be talking alongside such a talented panel. Um, so, essentially, Science to People, as the name suggests, is all about how people today are consuming health and science information and how much of it is grounded in good research versus a lot of misinformation that's spreading online. And it started with thinking about how that process can be facilitated and the role that AI can play in really helping democratize that information, but also helping reach people where they are in a way that resonates with them and is also culturally relevant to them. So that's where this organization started. And what we're building is essentially an infrastructure of this communication for health communicators. So, your health communicators are people who, in today's day and age, are the bodies from which you get your information from. So, they could range all the way from public health agencies who run campaigns to physicians who you sometimes meet and they explain things to you, to all the way to social media influencers on Facebook, TikTok, where we keep scrolling and we hear so many different things from different influencers, which may or may not be grounded in facts or scientific information. But on the other side, these influencers are relatable to a lot of people who are lived experience with living with chronic diseases, etc. So, how do we help reduce the amount of misinformation online to ensure that the information that people are consuming is good and helps them make healthier decisions? So that's essentially where we're integrating our AI platform in to help all of these communicators build communication materials, which could range all the way from a blog, a campaign poster to a TikTok reel, whatever they want to build, taking it only from peer-reviewed scientific research and helping them translate it into audience-ready scripts in a way that's faster, saves them a lot of time as well as resources. And the reason we're doing this is because today's AI, generative AI, is not equipped enough to facilitate this well, because there's a lot of hallucinations when it comes to the quality of information, as well as there's a lack of understanding when it comes to the audiences that are meant to reach. It often stereotypes different types of audiences, doesn't know how young people talk today. So we're trying to solve for all of these things specifically in the communication angle, and we're set to pilot our product in early next year. So we're really excited about that.
Oh, wow. No, congratulations for pulling something this important, and our good luck with the pilot that you'll be conducting very soon. Next, we move on to Dr. Luigi De Angelis. Luigi is a medical doctor from Italy, and he is the president of Italian Society for Artificial Intelligence in Medicine, and also a co-founder of Human Truths. So, Luigi, can you tell us a bit about Human Truths? What it does and why you started it, and also what the Italian Society for AI in Medicine focuses on?
Yeah, thanks a lot for the invite. Happy to see some familiar faces here. And so let's start from Human Truths. So Human Truths is a platform to streamline the research process from the survey design to the data collection and analysis. I think the data collection piece is the piece where we're most game changers, because what we are doing is leveraging voice agents that are multilingual and human-like in their way of interacting to collect behavioral data at scale. And we are focusing on collaborations with public health stakeholders, a humanitarian organization. We're now running a pilot in Kenya funded by the Gates Foundation to really test this novel technology out there in the real world. And as you might know, to collect qualitative data at a large scale, it's right now impossible. Like, you are limited by the sample size you can reach from a small focus group. But leveraging voice agents that can interact through a web call or a phone call, you can collect data from the population at scale, at a faster pace, and these insights can be then used to make more informed decisions for public health programs. And in parallel with this global effort, I'm also running a more local one with the Italian Society of AI in Medicine, which is a no-profit organization that was created 2 years ago. And it brings together different people with different backgrounds and expertise to create an ecosystem, bringing together all the relevant stakeholders in Italy to push forward the integration of AI into the clinical workflow. Right now, we are operating only in Italy, but we are more and more trying to engage with other partners in Europe. And I think there is a need to have this kind of multidisciplinary approach to drive change.
Well, sounds fantastic, and I'm really looking forward to our discussion as we unwrap the session and dive deeper into like your experiences and I think there's a lot to learn from you, Luigi. Thank you for that. So our last panelist, we kept our favorite panelist as the last. No, I'm kidding. I'm kidding. We respect our panelists equally, and we have no biases here. Dr. Charisse Dunn. She is from South Africa, a PhD in medical biochemistry and a health entrepreneur. She is the co-founder of South Africa Makes and also co-founder and CEO of Impact Mechanica. So Charisse, can you tell us about Impact Mechanica, what you're building, and how AI fits into it? And also share a bit about South Africa Makes and innovation ecosystems you are helping shape.
Yeah, of course. Thank you so much for having me. This is amazing. My name is Charisse. I'm a biochemist who unexpectedly found herself working at the intersection of AI, additive manufacturing, more colloquially known as 3D printing, and now sports health innovation, bizarrely enough. Like you say, I come from South Africa, and my family has been deeply affected since I was a kid by chronic disease and cancer, which is ultimately what led me into a healthcare career. And this is where I started to co-found healthcare innovations, one of which was South Africa Makes, where we are a point-of-care medical device manufacturing company. So we used to create, before the MPH, patient-specific heart models, things that would help design and further develop surgical tools for clinicians working in low-resource settings like South Africa. And eventually we created Africa's first 3D printed COVID-19 swab. And now, since graduating, I lead Impact Mechanica, where we're building AI-enabled custom-fit protective headgear. And this is very cool. I'm absolutely loving this and having a lot of fun with it because we've partnered with a really cool company in the US called Carbon. And they are the same company behind the protective head liners used in NFL, baseball, and ice hockey helmets. And our goal here is really simple, is to protect players before they become patients. especially in communities where a traumatic brain injury and repetitive concussions over the lifetime of a young player's career, even if it's an amateur or aspirational career, can really shape the rest of someone's life. So for us, this is a real serious public health issue. And in places like Kailicha or Cape Town, where they have these repetitive injuries, they can face a lifetime of elevated risk or cognitive decline, mental health issues in South Africa in particular, which is a huge problem. We've got a really significant unemployment burden and long-term disability case. And so we feel like at one stage in the future, these people could start relying very heavily on our already overburdened public health system. So we're incorporating computer vision and AI-enabled, hopefully user-friendly technology on smartphones that rightfully so. Dr. Patel had mentioned that we may or not have running water in every single corner of South Africa, but you can be sure that pretty much almost everyone has a cell phone. And so we're trying to find for our context-specific needs, what are the ways that we can reach people where they are to help them improve their circumstances right now and protect their future health.
Wow, and this is amazing, and I'm very happy to have such an amazing and diverse panel today. So I will just get into the questions right away, and in the interest of time, I would request the panelists to keep the answers short or the discussion to the point, so that we all, like the audience and attendees here, can get most out of this session. I will start with Matteo here. Matteo, you're working inside a health systems. What's one comforting assumption the global health world makes about AI that completely falls apart the moment you try to deploy it?
I think one of the key considerations to have is that in order for these machine learning models to be produced and to actually have impact, and in order to provide AI, there has to be data. And that data trains the model, that data understands how the interventions work. And then when we go to a health systems perspective, there is large information related to large data sets, some siloed to specific diseases, some more organizational health systems perspective. But when we go to the granular level of data, we come with some health systems, and most of them, that don't have as much as quality data at the granular level. And this is where AI is important. So there are several algorithms that can correct for that, but it's also a very important consideration to have, such as when we implement AI, there has to be data systems that work within the systems that AI works. So that's one big assumption there. And then another big assumption, or something that we talk a lot in global health, is that an intervention that works in a specific context for a specific country not necessarily works for other countries, and you have to be very context specific about the use of interventions in global health. And I do believe that AI brings a lot of potential here, because the perspective behind AI is how to individualize care, or how to personalize delivery of health within the global health ecosystem. So I do believe that when we are trying to implement AI, there are several assumptions that we have from the background of global health that need to be working from both sides. So we have a lot of assumptions from global health to AI, and a lot of assumptions from AI to global health. And I believe that those are like the two key points that I wanted to make for this discussion.
No, that's super cool. And in order to like push forward this discussion, I would like to bring in Charisse as well, and particularly from this aspect that, like, in your work, building AI-enabled protective gear and leading innovative efforts, what's a major implementation challenge that people outside your context, or I would say South Africa or even Africa, often underestimate?
I think one of the biggest things really is the reality on the ground. So this idea that a breakthrough product automatically becomes or is synonymous with breakthrough adoption. We are currently developing this AI-enabled app that will help people monitor their safety, player safety, track patterns of movement and head impact and trauma, and identify early warning signs of risk, right? But implementing any kind of AI technologies in communities where there's very limited medical infrastructure requires a lot of trust building interventions, education, reliable connectivity for sure, and consistent follow through and support from that healthcare community, network. So, and I think people really often underestimate how much time it takes to build those relationships. So we are running this now with coaches, parents, players, and it's really difficult to validate AI tools without consistent, high quality data from them. So you really need to be working with the people on the ground. So for me, no matter what kind of project I've been working on, particularly now, the challenge is never really the technology. It's everything around the technology that determines whether it actually works in real life and in your specific country of application.
No, great. And also I would believe that it also changes from context to context and experience to experience as well. And that's where I also would like to bring in Luigi. And from your vantage point in a national AI society and through human truths, what's the thing that AI developers consistently get wrong about human behavior and community dynamics and the real world use?
Yeah, thanks for your question. I think it's a very complex one. I'll try to break it down from the population perspective and the healthcare professional perspective. So, at the population level, people feel surprisingly comfortable sharing private and sensitive information with AI. And that's a behavior that we have not considered carefully in the design. And it just like if you see how people daily interact with ChatGPT, how comfortable they are sharing very private, sensitive information, I think that's important to notice. And if we are aware of this, we can design voice agents to collect behavioral data or also to design interventions and provide information to the at the population level, engaging in a conversation where people feel they're in a space that is not judgmental, and there is a lower barrier in sharing some information on sensitive topics. Some early research confirmed this. For example, for gender-based violence, people feel comfortable talking with AI. And then from the healthcare professional perspective, I think something most developers get wrong, and also at the policy level, is the explainability requirement, because everybody talks about having explainable AI, and also we know that the AI Act is focused on this transparency requirement. But what is really important is not understanding the inner working of the models. And maybe we can't for some complex model like LLMs. What we really care about is having some system that are available for the healthcare professionals to interact with and that can support awareness in the decision making. And this important piece of explainability is, for example, communicating when there is uncertainty and engaging in this kind of shared decision making where the healthcare professional has to say the final word but needs to understand the output of the model.
So am I correct to understand your stance is that even if the model is a black box, as long as it's giving good results, it's okay to use that model?
Not really. It's not only about the results. It's more like we don't need to focus on methods of explainability that gives that illusion that we understand the model, like, for example, heat maps for images.
Yeah.
We'd rather focus on explainability models that are oriented towards giving some justification for the output that can stimulate and engage and can be interactive. So let's think about LLMs. If we design them correctly to support clinical reasoning and engage in that kind of conversation with the doctors, I think it's much more helpful than trying to go back and track why exactly we had that output. So I can share a great paper about this because this conversation would take way longer than our panel allows.
No, thank you so much for sharing your insights on this. And since we are talking about some implementation reality checks, people, this whole discussion cannot be perfected without bringing in communication. And for that, we have an expert in the form of Rajeshwari here. So for you, Rajeshwari, what is the most common communication failure you see when AI is introduced into public health environment?
So, we actually in our work spoke to so many people in public health professionals who are currently in some form using AI or not using AI, as well as communicators of other forms like journalists, etc. And there is a certain pattern of mistrust when it comes to communication, and that is mainly driven by a lack of factual accuracy. So it's hallucinations is something that has not solved for yet, and it still continues to be an issue. But at the same time, uh, it's sometimes gets worse the more generalized the AI gets. So the bigger the foundational model, sometimes the worse the hallucinations are. Uh, and that leads to a lot of harmful outputs. And it eventually leads to them steering away from the AI usage itself. Another important part of it is an understanding of the audience. So if there is a need to communicate with young people, and we specifically instruct the AI the same. The AI doesn't speak like a young person, it speaks what it thinks a young person speaks like. And so that difference is often like quite evident. So it says, um, I've seen AI messages which say, "Hi, young adults, let's talk about cancer." But nobody talks like that. So it's not useful, and then there needs to be a lot of reworking done on it. So it becomes a little hard for AI to then be useful in order to communicate. And then the third thing is that it often gets very prescriptive, even if when not asked for. So gives you information of next steps and things to do, which may not necessarily be true, or it may not even be the point, but it sort of leads to this repeating cycle where you want to keep going back to the AI because it gives you such confident sounding answers.
Wow.
So I think that's the third big thing. So we want to ensure that we're solving for all of these things to make sure that that people have a platform they can use that's steering away from the current inaccuracies that AI is giving, because it does have a lot of potential if it is like built very mindfully for communication itself. So yeah, I think these are the three main things I'd say.
No, thank you so much. And I would continue this discussion and ask a very directed or maybe a loaded question. So, what erodes trust first when AI enters a public health space? Is it the technology, the messenger, or the message itself?
Oh, I think this is not a question that can have a single answer. Um, when it depends on whose trust it is. So I think when we're speaking to the communicator, who is the human in the loop using the AI, at least for us, AI is often used by the general public too. But in our case, it's mainly just the technology and the output. But for the public, it could also be the messenger, because the public, something that I say versus something that someone they trust says, even if it's the exact same thing, has different weightage. So from that perspective, whether or not AI was used is a secondary thing in and of itself. So that's why we are focusing so much on the messenger when it comes to what the public should listen to. Because if we
Right.
tell the public to listen to a robot uh, or any kind of AI, they may or may not, depending on their comfort with technology. And because there is no human or expert in the loop, it could also lead to like worse outcomes. So we want to keep it one step away from the public. But at the same time, for the people, for our users who are essentially public health communicators of different kinds, we want to ensure that the technology, what we're building and how we're building it, is extremely transparent to them. So it doesn't seem like we're pushing something onto them or trying to condescend in a way that, oh, you are not talking scientific and here's what you should speak. We're trying to act as if we're just empowering their current existing work with offering a faster way for them to get good quality research in helping their current work, which is already pretty great. So
Right. So I will now also bring in Matteo, like from his work's perspective, and ask a question around a very similar framing, but I would like an answer that's short and sweet. So for you, Matteo, when working with ministries or frontline teams, which part of an AI rollout do they question most? Is it the data? Is it the model? Or is it the intent behind it?
Yeah, I think trust in AI and health systems has been perhaps trickling down during time because of generative AI, and people understand AI from a very perspective of what they see. So governments see ChatGPT and they see that ChatGPT or these overall other LLMs hallucinate. So they think that AI, which we intend to work with health systems, which is real people that will be impacted by it, they are mistrustful, right? Like, and with they have all the data to back up why they are. Um, but there are different types of AI, as we saw during the presentation. And there is it's very important to let the ministries or health systems perspective to know that there are different ways of implementing AI, not just ChatGPT or not just recommendation system, but also at the interventional level on having a personalized intervention for specific behaviors that we want to change within the population. That is also one important key factor. And then I would definitely stretch a second one, and is that there is a lot going on around data governance. And for sure, if I were a government, I would also be really looking forward to how do we govern data that within our health systems. And health policy and health systems is lagging behind on health policy related to AI implementation in health. This is the case in Kenya. We're trying to implement AI within community health workers, but there is no guideline or no policy on how to implement AI in health. So, of course, there are different mistrusts and there are different questions that governments ask with all the truths behind it. But it's also understanding that, of course, there's all of these that we have talked about, but there is also a lot that can be done within AI and health systems.
No, great. That's a wonderful take, and a complex one, like the
Yeah.
like the thing that we're discussing today. So now we looked at like some of these examples from the community point of view, and I would like to bring in you, Luigi, here, and I would ask like when clinicians reject AI, what's actually happening behind or beneath the surface?
Yeah, this one is surprisingly easy because what's happening is fear, and it's something that we should be aware of. We are afraid of change, but the way I try to reframe this when talking with other medical doctors is bring them a broader perspective because medicine has always been changing and it's changed quite a lot in the past few years. Just think about evidence-based medicine. So of course, AI can bring a paradigm shift, but it also gives us the chance to rethink from first principles. So How are we allocating the time of medical doctors today? Most of it is spent for administrative tasks and not directly on the patient and doctor relationship. I think also looking at the burnout rates of doctors all over the world, AI is a great chance to rethink from like this bottom-up approach and say, okay, how do we want to spend our time? And can we redesign our profession with the help of AI? I think that's an exciting perspective and can help us to overcome the fear.
That's great. Sounds great. Yeah, makes sense. Now I move the conversation towards some locally led innovations. And there I would like to bring in Charisse, because like you've built locally manufactured AI-enabled products. What structural barriers to locally driven innovation do you see that global health conversations consistently overlook, sorry?
Yeah, I think largely what gets little to almost no attention is this missing infrastructure for continuity. So in Africa, all around the world, really, we've got really brilliant innovators. What we don't often have is regulatory clarity or efficiency. In South Africa, certainly very limited manufacturing pathways or entry points to make a dent, especially in healthcare infrastructure. I think we all know about the limited financing structures that many of our countries experience that allow prototypes, with software or hardware, to become real world products in spaces that really need these things. So it's the same as when we were creating the local COVID-19 swab, and it's the same now with Impact Mechanica. The science around these solutions is never really the truly hard part, but it's navigating these fragmented regulation systems, trying to get new and more efficient policies in place that don't want to be told that the global north knows best or has done it longer. And there's a lot of respect for context-specific policy. But it becomes really frustrating if you're an innovator that requires, a fast pace of movement and iteration because you want to create something that's really helpful and meaningful for the needs right now, if you can't get over that regulatory hurdle. And so we currently face in South Africa, how do we certify these AI-driven predictive hardware, predictive acts, in the space where AI usage in sports medicine is very limited, or the understanding truly isn't there for wider adoption, especially in the spaces that really, really need it. And so that's going to be a huge challenge for a long time, and it requires a lot of good, solid communication, I think. But yeah, it's something that we work towards constantly.
No, great. Thank you. Thank you so much for sharing your insights on this. And I would like to talk a little bit about Luigi's project in Kenya, but I would then again would like to remind panelists to just keep it sweet and short, and because after this we are going to get into lightning round in the interest of time. So for Luigi, like through Human Truths, I know that you're working on a project in Kenya that collects community voices about vaccine confidence and uptake. Can you share a little bit about the learnings from this project and the importance of community involvement?
Yeah, thanks. This project is the one I was referring to at the beginning. It's funded by the Gates Foundation. It's still in early stages, so we don't have results to share, but what we can share is the approach that we're using. So we want to test on a perspective study, real world, how these voice agents perform in collecting data, both in English and Swahili, on the topic of vaccine confidence and uptake. And we're going to run two separate studies. The first one is to compare the different recruitment methods, because we're going to be reaching these people through the existing methods, so panels, random digit dialing, social media ads, as well as text message and WhatsApp outreach. So we're first going to compare how these methods perform. And then we're also going to do the second part of the study, which is a head-to-head comparison of the same survey run by human enumerators over the phone and by our AI agent, and on a sample of 800 people. Then we're going to be able to do a blind external evaluation of the transcripts to go through and check some indicators and variables about depth, consistency, and all these different metrics to actually show where AI can be better than human enumerators and where the human enumerator is still needed to gather some insight. But yeah, very excited, and hopefully in a few months I will have more results to share.
Oh, wow. Good luck with that. It does sound like an amazing project. It cuts so much time and the hurdles for people who first have to employ people who can make the calls and do manual lot. So it gets lots of manual work there. So no, great. Looking forward to the results of it. Now we're just getting into lightning round because we're just at time. So to all the panelists, in one sentence, what must global health institutions stop doing or start doing to make AI more equitable over the next 5 years? Luigi, one sentence.
Hear the voices of the communities.
Hear the voice of the communities. Charisse.
Echoing that, we need to stop piloting AI tools for the communities and start building it with them.
Matteo.
Oh, echoing before, but creating models based on data from the real people that we want to intervene.
Rajeshwari.
Creating a policy that acknowledges AI usage and integration in the first place to set standards.
Great. And I'll get to my second question. Again, lightning round. In one sentence, where is AI in global health most overhyped and where is it quietly underperforming? Matteo.
Well, I think Gen AI is very overhyped, and there are various things that can be done through prediction models and interventional models through behavioral interventions. I think that's something that global health is lacking behind in AI.
Great. Luigi.
I would say it's a bit overhyped right now on automating data analysis, but it's only because it's the agent that allow to do this are something new, and we always underestimate the impact in the long run and overestimate in the short run. So I think it's only about time.
Charisse.
I think overhyped in the examples that I've seen, quite honestly, patient-facing chatbots being the answer for all in terms of like really cutting-edge diagnostics in rural settings, particularly.
Right.
Yeah.
And Rajeshwari.
Overhyped, I think a lot of B2B AI when it comes to integrations is a little overhyped. From my readings, it shows that the ROI to the cost that it takes institutions to convert is not seen yet. So
Cool. So last question, one-liner. If you could redesign the relationship between global health institutions and AI developers, what's the first thing you'd change? Let's start with Charisse this time.
I would change who is in the room from day one.
Luigi.
I would say vocabulary and finding a common ground for understanding each other.
Matteo.
I think that nowadays we're seeing a lot of people that don't have the background of understanding global health come from a very technical perspective on AI. And having people that really understand the mechanisms and the logics of the problems behind global health is not just about having the technical people that go behind AI.
Perfect. Rajeshwari.
I think I echo everything. An antithesis almost to what Matteo said is a lot of global health people, from what I've seen, just communicators, etc., are anti-AI because of various reasons to open their minds out to how it can possibly help could also be helpful.
Great. Wonderful insights. We are almost over time, and actually, we are over time. But thank you so much to all our panelists today, Charisse, Luigi, Matteo, Rajeshwari. I mean, you've been very kind and generous with your time and also with your insights. It was such a great learning experience for me, and I'm pretty sure it was a great learning experience for the attendees as well. And I would also like to thank all the attendees for who partic or who were part of this session. I hope that you got to learn some new perspectives through this conversation. And we also have a recording of this session on the CUGH website, just as Elizabeth has written in the comments. Again, thank you so much, everyone. It's been a pleasure.